Carol Rosen here. I'm a pediatric sleep medicine specialist. I've come to sleep medicine by way of pediatric pulmonary, but I've worked hard in my career to be a physician for all things pediatric sleep. I got involved in pediatric sleep medicine really early on. I was doing my pulmonary fellowship and pediatric pulmonary fellowship at Texas Children's Hospital in Houston. And I'm going to date myself, but that was the infant apnea near-miss SIDS days. And as a pulmonologist, I was interested in infant apnea. And there was a epilepsy monitoring unit that was studying infantile spasms at Texas Children's Hospital. And I went over with my little infant apnea monitor, and now I'm dating myself again. Pulse oxes were just coming out, and there was something called the Nellcor N1000, and it had saturation and CO2. And so I took these two pieces of equipment over to this research lab that was studying infantile spasms, and it was video EEG. So there it was in late 1970s, early 80s, and we were doing pediatric polysomnography before it was cool. It was about infants, and I had this very naive idea that, if we added the respiratory and cardiac to the video EEG, we'd figure out what SIDS was. Now, we didn't figure out what SIDS was, but that was actually the beginning of my career before people were really into pediatric sleep medicine. And so I came through the peds pulmonary door. And so I was in Texas from 78 to 86, and I had some adventures there. And we actually recorded a Munchausen by proxy case, and actually had video documentation of someone harming their child to get attention for themselves. And that was my infamous beginning in pediatric sleep medicine. I eventually left Texas and went back and did some more research training, and then I ended up at Yale New Haven Hospital with some control of breathing people. They were excited to have me because I'd had this sort of video EEG and pulmonary experience, but I only knew the infant part. And so I had to kind of get myself up to speed to think about apnea in older kids. And I didn't really know the neuro part or the behavioral part. And I used to go from New Haven, I would take the train up and visit my new friend, Judy Owens, and that's how I learned some of the behavioral parts. I remember early on as a pulmonologist, I saw this really sleepy guy with lots of leg movements, and I didn't recognize my first case of narcolepsy. And I remember talking to Art Walters at one of these meetings, and I was telling him about my sleepy guy with his limb movements, and I remember him saying, "My dear," he said, "your patient's sleepiness is out of proportion to the limb movements." And it was like a duh moment, and so that's how I kind of became pretty good as a narcolepsy physician, and I don't think I've ever missed a case since that time. But it's been pretty circuitous, and I've had lots of people kind of helping me on the way, becoming that complete pediatric sleep medicine physician. in terms of getting involved with the AASM, I think my first meeting, ASM meeting, I traveled to Toronto, and I met someone who stayed as a friend, a pediatric pulmonologist named Lee Brooks, and he's at the meeting today. And he took me to my first Major League Baseball game. And we watched the Toronto Blue Jays, and I remember being struck, who fills out those scorecards? Well, Lee Brooks fills out those scorecards. So there's been many kind of interesting experiences, but that was my first ASM experience. And I've probably been to every ASM meeting since that time. I think that was 1995 that we were in Toronto. I stayed with a career as, general peds pulmonary and sleep. I was at Yale New Haven for a decade. And I wanted to get more into epidemiology and clinical research. And I remember the person I most admired in the whole world professionally was Susan Redline. And one day my phone rang and I got a call. And it was Susan Redline saying she was in Cleveland and she had gotten a big NIH grant to look at pediatric obstructive sleep apnea, and what would it take for me to come and work with her? And I thought, it would take nothing. I will be there. This is just how I wanted my career to go. And so that was in 1999, and I went to Cleveland, and I stayed there at Rainbow Babies and Children's Hospital for 21 years, and after about a year, then I was complete pediatric sleep medicine, and I ran the sleep medicine program there, and we had trainees and patients, and I slowly got more involved in the AASM through various committee work. And then, in terms of my involvement with the AASM, my good friend, Ron Chervin, who was honored this year as for excellence in education, he said, Carol, you should put your hat in for the ASM board. And it's something I had never thought about. I think I was known in peds sleep medicine, peds OSA. He said, I think you'd be really good at this. And he said, don't worry, put it in. You may not get selected the first time, but give it a shot. I think you should do this. And I listened to him and I put my hat in the ring. And eventually I was selected to be on the ASM board. And I just finished my 2 terms on the ASM board. And I have to say, I just feel like I really grew in that role. The first 3 years, I still had a day job. The second 3 years, I had wound down and moved to Philadelphia to be closer to family. But I just feel like this last 3 years, and my term on the board just ended a couple days ago, it was a wonderful soft landing for my career in peds sleep medicine. And when I joined the board, I had, I call that Carol 2.0. And then when I stopped seeing patients, when I joined the board, I was Carol 1.0. And in my second term, I was 2.0 because I'd moved to Philadelphia. And when we ended my term on the ASM board, I was pretty sure, it's my soft landing and not seeing patients anymore, still doing some teaching in leadership and science, that I was 3.0. And I probably should have brought it for today, that my gift from the board was a ASM t-shirt that said Carol 3.0 on it. And that's my story. In terms of leadership, there was a change in the executive director. And so I came in just as they were selecting a new executive director, they had someone who had built the board up for many years. It got us in a good financial place. The board had a history. I was actually on the rogue board in terms of question writing for the exam. So I'd had some sort of leadership educational experience there. But this was a new board, new executive director. And I think in this 6 years, these 2 terms, I just feel like the board has just grown enormously. One of the really positive things that happened is we hired a consultant group and we did strategic planning. Who were we? What did we want to do? What were our goals? What were our objectives? I feel like that was a real game changer for the board. It just kind of got the path clear. And then when you think about what did you talk about during the board and what did you work on, you wanted to make sure those things were aligned with your strategic goals and objectives. And I just, people came and went on the board and it grew, but we began to think of ourselves as, what is it that a board does? How does it provide leadership? How does it look towards the future of sleep medicine, which is a little scary these days. So, well, what are we dependent on? We're dependent on polysomnography. And is that our future? I mean, I just kind of see the field going maybe upside down. There may be very new ways that we make diagnoses. And I have to say, I'm feeling a little dino. I'm feeling a little bit like a dinosaur, because how did my career begin? I kind of it began with polysomnography way back before it was even cool. And that was kind of foundational. What was I really good at? What was I known for in teaching? And if you talk to people who'd been my fellows, they say, oh, I remember Carol and her teaching and her hand movements and all the things she could point out in polysomnography. And now the polys are kind of disappearing and we're getting more limited channel. And maybe that's enough to provide efficient care. And so I wonder what's going to happen to our field. I've enjoyed my narcolepsy patients. And is PSG-MSLT the future? Or are there going to be very, more efficient, more physiologic ways of understanding and diagnosing that illness? Pediatric OSA, we've been dependent on polysomnography. So if I think about my field, but there's a lot of labs that don't accommodate children. And it's a big deal for a family to have polysomnography, and it's kind of one shot and not everybody's as good at it. But do we need all those signals? And, what's more important, the physiology, or can you get that in a more limited way? And are symptoms more important? So I feel like, how our patients come to us, what our diagnostic testing is, how we're going to manage them. I mean, when I first started, in terms of narcolepsy, there were hardly any medications. We were using our ADHD medications. And now there's so many different kinds of medications. And how is it that we manage insomnia? And what are we going to do about RLS and narcolepsy? I mean, things are just changing diagnostically and treatment-wise. And the practice environment has gotten a lot more challenging. People don't really understand what you do and what you need. And especially for pediatrics, people are always kind of in adult mode in terms of how you offer services. So those are some of the challenges. The strategic goals that we set had to do with, now we're going to have a test. Public awareness is really big. And the board has really worked hard to make sure that the public is aware about the importance that sleep is essential. And we've made some big investments that particular goal. And workforce development. With these more limited channel studies, what's going to happen with our PSG techs and polysomnography? Is that going to be our big future pipeline? Is it all people with fellowships? I think we really need to welcome nurse practitioners. People are having a lot of trouble keeping sleep techs in their labs, and that's affecting access to polysomnography and, improving patient care. We're seeing all kinds of new developments, medications, diagnostic strategies, devices. So the board has talked recently again about next, it's been 5 years, more strategic planning. And I thought, gee, I think what we're doing, I think we've kind of nailed the really important stuff for our field. And the thought was, well, maybe our goals are pretty close. And maybe the objectives need to change. And that was a reassuring thought. And actually, even though I've come off the board, I still have an invitation as a wise senior person or PD voice or whoever I am. So I'll get an opportunity to go in September for the next round of strategic planning. But I feel like that was a real kind of a game changer, quality improvement thing that happened kind of during my term on the board. And I guess that's how you function well in leadership, is to be the best you can and think about what you do and always try and do it better. The Academy has, I think, overall had increasing support for pediatric sleep medicine. In some sense, I think sometimes we always felt a little bit on the outside, especially in our local institutions. I guess when you think about sleep medicine and local institutions, there was a sleep lab, and it was a great, I hate to use this term, cash cow for many departments, and it was sort of OSA-centric. But I think by bringing pediatrics in, you had to make the labs a little bit more welcoming for all kinds of people, accommodating caretakers, and caretakers not just for parents, but maybe caretakers who might have come with adult patients. I feel like pediatrics brings so much richness, pediatric sleep medicine, to the field of sleep medicine. And for a lot of the adult people who say, oh, it's not in my scope of practice, I shouldn't think about it. I guess I feel that we have so much more in common than we do separate. I mean, the only thing we don't have is we don't have REM behavioral disorder. We got a little bit of it with our narcolepsy patients, but we really share so much. And if you think about sleep medicine and you're kind of more patient-centric and family-centric, you realize that sleep is essential, that families will set good role models for healthy sleep practices in families. OSA can run in families. Narcolepsy can run in families. RLS can run in families. And that because it's such a broad field, we actually have lots of lessons and common interests and for sleep medicine practices. When you've accommodated children, you've made things better even for the adults and for your elderly patients. When I think about the developmental aspects in sleep, one thing I can be very thankful for, and a change that I saw in the board and in the ICSD, there was 1, 2, and 3. So I've and now there's the revision. I see SD3, and I have to be thankful for the board and the group that did that. There's now every single disorder has in the description, there's a developmental aspects. And so that's a way in which the board and the field grew. It wasn't there in 2, and the disorders were actually separated. There was adult OSA, peds OSA, and they're still a little bit separate. But by putting in the developmental aspects, I feel like they brought the field forward, and I am grateful for that. There have been a number of, rock stars for pediatric sleep medicine. And certainly somebody like Mary Carskadden and her work in narcolepsy and MSLT and how sleep changes and the teens and developmentally your circadian clock moving forward. So Mary was a major contributor to that, and it was such a delight to see her honor this year. Over my years in sleep, I got to know Judy Owens very well, and I mean, she really helped me get through the developmental, behavioral kinds of things, and she's been a big contributor about teen sleep. And now you see the whole ASM looking at standard time and what that does for teen sleep. And so a lot of the problems there have to do with early morning waking and early school start times. And so it took a while for the ASM to kind of get on the school start time bandwagon, but they're there now, and they've partnered with other organizations. So I guess I see over my time in sleep medicine, bringing in that's the richness that pediatric sleep medicine brings to the whole field of medicine. And I can't say enough about Susan Redline, and she's in internal medicine, adult pulmonary, but how I got to grow in sleep was her grant to look at pediatric OSA. So there have been a number of people. Ron Chervin would be another example. People whose careers were in adults, but looked at the richness of pediatric sleep medicine to really enhance the field. The AASM is one of the best quality experiences that I have had. They have the back of the field that I have my passions about, and I am very grateful for the opportunity to have been involved in professional leadership with the ASM board. I will be eternally grateful for that.